website. Patient-centered care, October 12th, 2022. Cancer-related pain management from a palliative care perspective with Cindy Kelly, FNP, BC, ACHPN, and Vanita Rao, PharmD, BCPS, CPP. So first off, Cindy Kelly. Cindy, FNPBC, ACHPN, is a nurse practitioner in the outpatient oncology palliative care team. Her experience includes working at the City of Hope in Duarte, California as an oncology nurse practitioner in the lung and solid tumor team, and later with the geriatric oncology team. Her palliative care experience includes both inpatient and community settings. She is board certified as a family care nurse practitioner with a certification in hospice and palliative care. Cindy completed her MSN at UCLA in 2003, and then with a postmaster's in oncology in 2005. Her interest is in mindfulness practices. Cindy, welcome. Thank you so much for being here today.
Thank you for having us.
Absolutely. And tell us what's one thing we should know about you outside of your professional bio there?
I really love the practice of meditation. It's really been a gift in my life. And right now I'm in the process, I've taken healing touch classes and I'm exploring Reiki therapy, the Reiki practice, and hopefully that'll allow me to listen better.
That is great. Thank you. Thank you for sharing that with us. And I also want to welcome Vanita Rao, PharmD, BCPS, CPP, and she is a clinical pharmacist practitioner in the outpatient oncology palliative care team. Dr. Rao graduated from Cedarville University School of Pharmacy in Cedarville, Ohio, and completed both pharmacy practice residency and pain management and palliative care pharmacy residency at Summa Health in Akron, Ohio. She is board certified in pharmacotherapy. Her clinical interests include early integration of palliative care for people with serious illness and supporting people with substance use disorders and palliative care needs. Vanita, welcome. Thank you so much for being here.
Thank you for having me.
Absolutely. And just like I asked Cindy, what's something we should know outside of your professional bio?
Sure, just something fun to share about myself. I am a big animal lover and a huge part of my life outside of work, and I currently own 2 guinea pigs, but I brought a tiny piece of my work into my personal life in that I named them both after medications as out of a ode to my career as a pharmacist. So I have Remeron and Rexulti, who are named after an antidepressant and an antipsychotic. And I can tell you they do very great work in their therapeutic purpose in bringing a lot of joy and to me outside of work.
That is great. Thank you so much for letting us know about that. I mentioned we will be using Poll Everywhere. So here's the first question. Cancer-related pain can have a large impact on a patient's overall quality of life. True or false? I think this is kind of a softball, but we'll leave it to our audience to decide. They can go ahead and use those instructions on Poll Everywhere to go ahead and answer that. While they're doing that, I will go through our disclosures. This activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Continuing Professional Development. The course director, CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. The University of North Carolina, Chapel Hill is accredited with distinction as a provider for nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. A potential conflict of interest occurs when an individual has an opportunity to affect educational content about healthcare products or services of a commercial interest with which he/she has a financial relationship. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with commercial interests as pertaining to this activity. And let's take a look at that first question. Let's see, that is not popping. Oh, okay, there we go. So that is, we'll wait a few more seconds, give everyone a chance to respond to that. All right. Cindy, Vanita, how are they doing?
Great. Perfect.
Okay. Well, we got the easy one out of the way. So there is an impact, and let's learn more. Cancer-related pain management from a palliative care perspective. Cindy, I'll turn it over to you.
Thank you, Tim. So the objectives today are going to be to identify analgesics commonly used in cancer-related pain, along with their method of action, dosing, and side effects. Also to strategize opioid prescribing for patients at elevated risk of misuse, and to list non-pharmacological measures that can decrease pain. So we know that the effects of cancer include more than just the physicality of the pain. For sure, there's the cancer pain itself, and then we also have the therapy or treatment-related pain. And, common examples of therapy or treatment-related pain can be seen in, for example, mucositis with concurrent head and neck cancer, where people are receiving chemotherapy and also the radiation therapy for 5 to 6 weeks. The second one that I really think about when I consider treatment-related pain would be that of neuropathy. So the hand-foot neuropathic pain that comes from chemo-induced neuropathy. We do realize that physical pain contributes to mental processes, and this can include anxiety, sadness, or a combination of both of them, fear, and even perhaps despair, as in, like, will there be any respite from this pain? And then socially, we know that when I connect with people in the palliative care setting, I always ask this question, like, what are their goals of care? And a universal response normally is people's independence, right? That's a common human reaction. And so potentially with pain, there's a concern that one's autonomy may be interrupted. And then the consideration of what's going to happen with their role as potentially a caregiver, a provider, their roles in their family. And then spiritually, the uncertainty, that's a hard aspect of, like, what will be for me in the future with this pain. And this can, come with it fear. And, maybe the question, what is the purpose of this pain? So in summary, we do know that cancer pain has all, the domains of the physical, sensory, mental, emotional, social, spiritual, cognitive, behavioral, and cultural aspects. For the prevalence, some of the literature states it's up to 64% of patients with metastatic or end-stage disease will have cancer pain. And again, the neuropathic pain, the therapy may be done, but, for some, the neuropathic pain can continue. And the research is showing that approximately at least 20% of the pain caused by cancer is associated with neuropathic pain. And they're finding there's an association with a greater analgesic requirement, poorer outcomes, and greater disability. One of the findings that I thought was really high is that up to 40% of patients have pain after their curative treatment. So for the treatment options, Vanita is going to explore medications in detail, and I'm going to talk more about the role of some of the other treatment modalities. So for the rehab, we have, the consideration of PT, OT, and speech therapy. And, I love the rehab team. They're very gentle. They TENS unit, working with lymphedema, or even the pelvic PT clinic can be very instrumental in helping decrease pain. And we do know that moving is so beneficial to one's well-being. So any type of gentle moving, it doesn't have to be a lot, but we know that moving in general is a good intervention to help people feel better. And often I'm asked the question, like, how much should I be moving? And, really it's this ability to listen to our bodies and their body to know what is appropriate for them to do. I normally encourage people if it's very difficult to move, like even any type of movement in their apartment or home is, can be beneficial. And then the integrative medicine consultation, I think their team has a close affiliation to our team in the sense that it's a holistic approach to care. My understanding of their program is that they're partners in the healing process, and that's how I'd like to see it from our team as well. The aspect that I really appreciate about the integrative medicine is that, as I was investigating more about them, is that for their team, there's this commitment to self-exploration and self-development, which I think is important for us as providers in helping with pain management to really to listen and to understand and to help serve the people that come to us in need. For the education, this is so important. I think it's the crux of like making sure that we're hearing people. So I always ask people, like, what are their goals of therapy? What do they want? And most of the time the response is, I really want to have a better control of the pain, to have my pain reduced so that I have more ability to function. That's usually a universal response, but sometimes I hear the response, I really don't want to take the pain medicines because I want I want to be very lucid. I want to be able to do my work. I want to have no sedation. So sometimes we might hear that is the goal, and we try to navigate within the goals of the patient. I also think that it's very important to establish the expectations of how we anticipate that the therapies that we're recommending may be beneficial. It's always this give and take, and sometimes we have to make adjustments sooner versus later, but we try to make sure that there's the ability to connect with our team to make sure that if we need to make adjustments, we can. And if we feel that the pain is of if we don't think we're ever going to get it down to a 0 on the pain scale, we share that with people, right? So maybe the goal may not be at a 0 out of 10, but maybe if we can get it down to a 1 or a 2 out of 10, maybe that could be the acceptable goal for both of us. Mind-body interventions, I'll be exploring later. And then with the interventional pain team, their team can actually do several things. So they're more invasive. They can do things such as kyphoplasty, sympathetic plexus blocks. And that's, for example, of like pancreatic pain from pancreatic cancer. They can do a celiac plexus block. They can do intrathecal, delivery systems. And also, this connection with the interventional pain team leads me into, if we have a patient in the outpatient setting that's having uncontrolled pain, sometimes our treatment modality is to have the patient admitted for uncontrolled pain, and then we would have our inpatient palliative care team follow up with them. And so sometimes what normally can happen is that people would be put on an IV PCA, and sometimes we try to transition them to oral medicines, but if not, maybe we need to do an intrathecal, or, having a PCA in the home is somewhat difficult to manage outside of the hospice setting, but it can be done, but it is more difficult to navigate. The other modality that sometimes is beneficial, and this would be, again, usually we see this as ketamine in the inpatient setting. And lastly, there's radiation oncology. So it's another team that I so value because, we see it so often, right? There can be a pleural-based cancer that's causing, much discomfort, or there can be cancer located in the subcutaneous tissue, the musculature, or a lymph node, or cancer in the bone. And my experience is that, when people connect with the radiation team and they say, yes, we can palliate this pain. And for the most time, it works. For most times it does work. So you get much benefit with little toxicity and hopefully even the chance to decrease the opioids.
All right. Well, thank you, Cindy. I will now be talking about some of our medication options that we have for pain. Although much of our time today will be spent discussing opioid prescribing, we do want to emphasize that there are a myriad of non-opioid options that can be used for pain, and often these options have a much safer side effect profile than opioids. So even if a patient has pain that does warrant an opioid, our team really does our best to maximize the use of these non-opioid adjuvant medications to make sure that we are hitting the pain from a number of effective angles with as little side effect burden and toxicity as possible. So the choice of these agents in part depends on the type of pain that your patient is experiencing. There's two kind of categories of agents that I have listed here, which are nociceptive agents versus neuropathic agents. So nociceptive here refers primarily to tissue damage. So words that patients may use that can indicate a nociceptive type of pain might be burning or stabbing, throbbing, aching, words like that. Neuropathic pain, as Cindy mentioned, is something that we see commonly, especially peripheral neuropathy as a result of chemotherapy. But there can be a number of sources of neuropathic pain or pain that involves nerve conduction. So words that you may hear that might clue you into neuropathic type of pain would include burning, shooting, or tingling. So looking at some of these agents, for nociceptive agents, we can use acetaminophen or Tylenol, as well as NSAIDs, non-steroidal anti-inflammatory medications, which are often over the counter. Steroids can be an option for a lot of types of pain, and these medications can also be really helpful for nausea and some other symptoms, but as many of you are well aware, they do come with a very high side effect burden, a lot of metabolic effects, a lot of infective risks, as well as if a patient's on immunotherapy, these may not be an option. So typically in our practice, these are reserved either for patients who have a very limited prognosis, more in the window of hospice care, or as a short burst of medications to relieve an inflammatory type of pain. So we may give somebody a steroid burst for a week or two and then have them plan to be off of steroids. There's a number of topical products that can be beneficial for pain. The advantage of these is that there are very few systemic side effects since they can often work right at the site of application without getting really absorbed into the bloodstream. So some options include Voltaren gel or diclofenac, lidocaine cream or patches, as well as capsaicin. Some common neuropathic agents that we use in our practice, they can kind of be broken down into three different categories of medications. So the first one are the SNRI antidepressants, and these would include two medications that we see commonly, duloxetine or Cymbalta, or venlafaxine, which is the brand name Effexor. The advantage of these two medications is that they can offer a two-in-one benefit. So they can provide that antidepressant, anti-anxiety relief, as well as treating neuropathic pain. So these are a favorite of ours in palliative care because we like when we can combine one medication to hit more than one indication so that we're minimizing medication burden for our patients. The other category of neuropathic agents is tricyclic antidepressants or TCAs. These include amitriptyline or nortriptyline. These are better, maybe second line options for neuropathic pain. The reason why we don't always use them first line is they do have a pretty high side effect profile. They're very anticholinergic, which means high fall risk, lots of drying effects, a lot of caution with elderly patients. If I am going to be using one of these medications, I do prefer nortriptyline to try that above amitriptyline because it's slightly less drying or anticholinergic compared to amitriptyline based on its chemical structure. Lastly, we have anti-epileptic medications, which would include gabapentin, pregabalin or Lyrica, as well as carbamazepine. This may be a medication you may not have seen as frequently for pain, and it's one that I would consider a last line agent, but it can be an option for certain types of neuropathic pain, especially trigeminal neuralgia. It does have a lot of medication interactions and side effects, so we only use this with a lot of caution. So next, let's talk about opioids. How do opioids specifically work to relieve pain? Opioids are mu receptor agonists. They work by stimulating central and peripheral opioid receptors, or these mu receptors, that then cause decreased messages to reach the brain where pain is perceived. So the mu receptors in our brain are what cause this perceived analgesic relief. But the fact is, our bodies have mu receptors all throughout in all tissues, and this includes mu receptors in our gut. So when opioids bind to those receptors in the gut, they can inhibit intestinal motility. And this is why constipation is one of the major side effects we watch out for with opioid prescribing. So talking more about some of these potential side effects, constipation, as you can see, I've highlighted in bold, since that's something to keep in mind for every patient. The rest of the side effects that I'm going to review are ones that with time, the patient will develop tolerance to. Constipation is the one exception to that. It never goes away, no matter how long a patient has been on opioids. So being vigilant about whether a patient's having regular bowel movements and prescribing a bowel regimen is something that's very key whenever opioid prescribing is involved. Other side effects, opioids cause a good degree of sedation and can cause cognitive effects, as well as respiratory depression being its major toxicity to watch out for. They can cause tolerance, physical dependence, as well as this phenomenon called hyperalgesia, which is a paradoxical reaction that we see when patients are on very, very high doses of opioids, in which they experience a disproportionate response of pain to a painful stimuli. So often when we're seeing patients with hyperalgesia, we're thinking about ways to come down on our opioid dose or move to another agent. Less common effects include nausea or pruritus or itching. These two are ones that patients may experience in the first few days of starting a particular opioid. Typically, these are very transient side effects and will resolve as the patient develops tolerance within a few days. So if I'm taking care of a patient who is reporting some of these for the first couple of days, I may encourage them to use antiemetics for the nausea and see if this side effect gets better within 3 to 5 days or so. So some considerations prior to prescribing opioids. What needs to be thought through before selecting an agent for a patient? Some characteristics include medication allergies, as well as previous opioid exposure and the patient preference. It's helpful to know if a patient has had a negative reaction to a medication in the past, and conversely to know if their pain was well managed on one particular opioid versus another. The severity and nature of the disease is a very helpful question to ask. So what is this patient's prognosis and their pain trajectory? Do I expect that this pain will continue to worsen, or do I expect that treatments such as chemo or radiation will actually improve or decrease the pain over time? Other questions to ask: is pain due to an injury that I expect that the pain will get better as healing improves? So thinking about where the pain is headed is an important question when you're thinking about whether opioids are appropriate and what to prescribe. Age of the patient and their functional status is one factor to consider, as well as the extent of their cancer, particularly renal involvement. Most opioids are renally eliminated, and this may affect which medication you choose or what dose you choose. Important to keep in mind comorbid disease states as well as dosage forms or routes preferred by the patient. So do they have a feeding tube or difficulty swallowing, for example? This will affect which options you can choose, especially with long-acting opioids, as these oral long-acting medications cannot be crushed or given through a feeding tube. So the best medication for a patient is really going to be the one that they will take. So cost and insurance coverage also play a huge role in selection. I'm going to try to move my computer a little bit to see if that helps with the sound quality. So apologize if I'm having some fading in and out. Thanks for the notice. So there's a number of factors to think about with dosage form selection. So I'd encourage you, if you have a pharmacist on your team, work with them to figure out issues such as insurance coverage and drug interactions that will play into that as well. And lastly, there's opioid risk assessment score, the opioid risk assessment tool is something that we'll discuss later in this presentation. And the point is that these are dangerous medications, and we want to be aware of an individual patient's risk and benefit ratio before we prescribe. All right, so here's a list of the most common options for opioids and their dosage forms, broken down into categories of long-acting and short-acting agents for your reference. I just wanted to highlight a few key points. You'll notice that oxymorphone, transmucosal fentanyl, and hydrocodone ER are listed in gray. I listed those for completeness sake, but the reason I grayed these out is that the reality is these medications are very challenging to use and even more challenging to obtain. Most pharmacies do not stock them, and most insurance plans do not cover them. So I would recommend looking for other options first. Tramadol is also a short-acting option, but I've highlighted in red to caution against its use. This is not a medication our team prefers because it's got very unpredictable analgesia based on the patient's genetics, and it has a risk of lowering the seizure threshold. We would much rather manage pain in a more predictable fashion with one of the options listed in black, such as morphine, oxycodone, hydromorphone, methadone, fentanyl patches, or buprenorphine. All right, so with this myriad of options, how do you choose the best medication for a specific patient? This brings us to our first poll question, which is, which of the following opioids should generally be avoided for patients with severe renal dysfunction, such as a creatinine clearance less than 15 milliliters per minute? I'll give you all some time.
All right, Dr. Rao, this is great. We're getting several different answers. How are they doing?
Well, this is kind of a challenging question to begin with. So overall, I'd say everyone's doing quite well. I appreciate the variety of answers. We'll talk about which one is the correct answer on our next slide. So patient characteristics to keep in mind with drug selection. It's important to note that the majority of opioids are excreted by the kidneys, and thus you may need to reduce the dose in patients with renal failure. So I appreciate that there were a variety of answers on the poll question, because all of these may be something you need to think about if a patient has renal failure. However, the one opioid that has the highest risk of adverse reaction in renal failure is actually morphine, which the majority of you actually did select. So well done. So morphine has toxic metabolites that will accumulate in renal dysfunction and cause neuroexcitatory effects such as seizure or myoclonic tremor. So generally, the recommendation is to avoid its use in a creatinine clearance of less than 15 milliliters per minute. It's also worth noting that most drugs are metabolized by liver enzymes. However, that does not mean that you need to avoid opioids or reduce the dose for hepatic failure. In fact, most opioid package inserts recommend no preemptive dosing adjustments based on liver function. So instead, the recommendation is to simply monitor for clinical response and consider reducing only if a patient has effects like excessive sedation or if respiratory depression is observed. A patient's nutritional status and albumin level will also affect the body's response specifically to fentanyl. Cachectic cancer patients with a low BMI and an albumin of less than 3 may not receive benefit with fentanyl because the drug will follow any protein that leaks out of the blood vessel into interstitial spaces. So if this happens, if a patient has low albumin, if albumin is leaking out into other parts of the body, the drug will follow it. It won't reach the brain to cause adequate pain relief. So these patients may not receive adequate relief. And then finally, be mindful of drug interactions. There are a myriad of possible interactions, but some highlights to have on your radars include anti-infectives and antidepressants. So again, I'd recommend check with your team's pharmacist for a more comprehensive medication review. So talking about changing opioids, even if you've selected an optimal opioid agent, you may find yourself in a situation where a change in opioid agent is warranted. Some reasons for change include a lack of efficacy of the agent that you selected initially, intolerable side effects, change in patient status, such as loss of oral access, practical considerations such as insurance restrictions or convenience of the dosage form. When thinking about changing an opioid, it's important to gather pertinent pieces of the patient's history, such as the cause of pain and the history of both their pain and the use of their medications to relieve the pain. Pain ratings, so whether that's 1 to 10 pain scale, or for some patients, it works better and it's simpler for them to qualify their pain as mild, moderate, or severe. Concomitant disease states, and then any history of allergies or preferences with opioids, as that may give you a clue into what will work for this patient's pain. Before we talk about conversions and dosing, I wanted to review a few helpful definitions to keep in mind. So the first one is equianalgesic, which is a term that describes when 2 doses of different opioids provide the same analgesic effect. So for example, we know that 20 milligrams of oral oxycodone isn't the same as 20 milligrams of oral morphine. In fact, it's roughly equivalent to 30 milligrams of oral morphine, which is about the same dose as 10 milligrams of IV morphine. So conversion charts, which I'll show you one example, will be really helpful to keep this in mind. Tolerance refers to the phenomenon that continued exposure to a drug reduces its effectiveness, and thus the same dose of opioid over time might not have as great an effect on pain relief, and will also not cause as much sedation and adverse effects. Even though a patient may develop tolerance to one drug, say morphine, for reasons we don't fully understand, the patient may not have the same tolerance to an equivalent dose of oxycodone. So this phenomenon of different responses to different medications is called incomplete cross tolerance. And it means that once you do your conversion from one opioid to another, you will likely need to reduce that calculated dose to prevent overdose and adverse effects to make sure the patient remains safe. This chart from NCCN is a helpful guide for opioid conversions. I've highlighted the conversions to focus on in the red box, since the other drugs are rarely used in practice. You'll note that methadone does not follow this conversion table, as the dosing ratio changes depending on the original dose of the opioid. For this med, it's best to rely on pain management or palliative care specialists for dosing strategies. But I also wanted to highlight here on the bottom of your screen that fentanyl has a very different conversion strategy. Fentanyl is dosed very differently than other opioids. Instead of milligrams per day, it is micrograms per hour. But rather than doing all the complicated math of going from micrograms to milligrams, you can actually use this quick evidence-based conversion to find an equivalent dose of another opioid. So if you look at the example on your screen, a fentanyl 100 microgram patch per hour, if you take that 100 and multiply it by 2, that gives you an approximate equivalent of how many milligrams of oral morphine that patient is getting in a day. The conversion can be used in the opposite direction as well. So if a patient is getting around 200 milligrams of oral morphine equivalents per day, if you divide that by 2, that gives you a rough idea of an equivalent fentanyl patch dose if you were switching them in that direction. All right, so now talking about opioid rotation, what steps need to be taken when switching a patient from one opioid to another? The very first step that I always review when I'm going over opioid conversions is to assess the patient's pain. So is their pain controlled or is it uncontrolled? Framing this before you do your math and your conversions gives you a good sense of whether in the end you would need to round up or round down, or how to individualize this regimen to the patient's need. Second, you're going to determine the total daily usage with opioids. So if the patient is on long-acting and short-acting opioids, you'd want to add up the total amount of opioid that they're getting from both medications in the past 24 hours. If the patient's on different medications, say they're on a fentanyl patch and also short-acting oxycodone orally, I'd recommend putting them all into the same category of opioids so you can get an idea of like how many milligrams of oxycodone or morphine that is. Third, you want to determine a new regimen for the desired opioid based on this total daily usage. So you'd add up all of your total daily dose and then convert this using a conversion table to the equivalent dose of the opioid that you want to switch the patient to. From there, you're going to individualize that dose you get to meet the patient's needs. So this is where keeping in mind their pain control is really important. One thing to consider is after you've done your math, you may need to dose reduce that new number to account for this phenomenon of incomplete cross tolerance. However, there are situations, say if the pain is very uncontrolled, that you may not do a dose reduction or even slightly increase to make sure that the patient's pain is controlled. Lastly, you want to break up that total new number of milligrams of your opioid of choice and divide it into a scheduled dose and a PRN or as needed dose. And of note, the PRN dosing should be equal at least 100% of the daily scheduled dose. So let's briefly look at a practice example. Say you wanted to convert a patient from an outpatient oral hydromorphone regimen to IV morphine to start a PCA for uncontrolled pain. The formula there is given for you at the top of the screen. So this patient is taking oral hydromorphone 12 milligrams every 3 hours around the clock for the last 24 hours. So after you've assessed the patient's pain, and let's say in this scenario, the patient has uncontrolled pain and you want to switch them over to IV morphine, PCA for uncontrolled pain. So uncontrolled pain, you want to add up how much hydromorphone they've gotten in the last 24 hours. So they are taking this medication 8 times a day if it's every 3 hours. So this means you multiply 8 times 12 to get 96 milligrams of oral hydromorphone. And then you're going to plug your numbers into this ratio here. If you look at the conversion table, the current dose of hydromorphone is going to be a 7.5 over the conversion factor of the new desired opioid, which is IV morphine at 10. And the numerator on the second side of the equation, you're going to put in the total daily dose you just calculated of oral hydromorphone to be 96. Then you'll cross multiply to find the new number of milligrams of IV morphine per day. So 96 times 10 is 960. Divide this number by 7.5 to get 128 milligrams of IV morphine in 24 hours. This gives you the total daily dose. Then to divide that into an hourly infusion, you divide that by 24 to get a basal rate of about 5 milligrams per hour for your basal rate of morphine PCA. Lastly, this is a lot of math, so the most important thing is to double check your work and to do this with a coworker to see if you both get the same value independently. In our team, we often refer to opioid conversions as math with friends. And no matter how long we've been doing this, we like to pull in another set of eyes and another brain to make sure that we're not missing anything and that the answer we came to makes sense.
So who is at risk for opioid misuse? We basically have 2 categories: moderate risk, those that have a remote history of drug or alcohol use disorder. And I hope you can appreciate that I'm using the word disorder and not abuse. Abuse has such, excuse me, a negative connotation, and really the preference is to use the word use disorder. A history of addiction with sustained period of recovery, questionable family history of alcohol or drug use disorder, smoking, history of physical or sexual abuse, and involvement with others who engage in illicit drug use. A higher risk could, there's just more intensity. So there's a risk, recent history of multiple episodes of alcohol or drug use disorder, history of addiction with limited or no system to sustain recovery, strong family history of drug or alcohol use disorder, history of major psychiatric disorder, younger age, and male gender. So we also have red flags of opioid misuse. Those include early refills, use of multiple pharmacies, obtaining controlled substances from multiple providers, diversion, where we're giving, patients are giving or selling controlled substances to family or friends, current or past excessive use of alcohol or drugs, marijuana use, use of street names for medications, inconsistent results with urine screens, driving long distance to seek providers for controlled substances, drug overdose, unclear etiology of the pain. And that's something we, try to do. Like we look at the scans, listen to the history and physical, do the exam, making sure that things line up, that's where we think that, where is the pain coming from? And then lastly, where there's this preoccupation with like, when and where am I going to get my opioids? So our team employs a opioid risk assessment tool. And when I present this tool, when I do this in the clinic, I go over it with the patients and give them the scores. So it's rated, low, moderate, or high. And if patients fall in the moderate to high, I do get a urine drug screen on that visit just for safety's sake. And actually the goal here is to create a culture of safety, right? I want to make sure that what I'm prescribing is going to help the patient, but also to do it in a safe manner and to make sure that, the patients are going to be safe.
So another helpful tool to use along with some of these risk mitigation strategies and to emphasize safety for patients with opioids is to order your urine tox screenings. The goal of this screen is to confirm that whatever opioids you're prescribing do show up in the urine on a UTox, and also to see if there are any other substances that we do not expect to see. I want to emphasize that this is not a punitive measure to order a UTox for a patient who is receiving opioids. This is something that is actually part of our safety agreement and our practice as a clinic in the outpatient oncology palliative care team. And we set this expectation with patients up front to let them know, hey, this is just part of our safety agreement to make sure that we have all the information that we need to make sure we're making the best decision for you to keep you safe, whether that's to change and move away from opioids or to continue them and be aware of what's going on. And just because something is positive here that we weren't expecting, that's not an automatic dismissal or an automatic reason that we would discontinue treatment or opioid therapy. But it does open the door for the conversations we need to have with patients to make sure we're doing this work safely. Along with that, there's 2 orders that we would recommend entering in EPIC if you want to order a urine toxicology screen. So the first one is urine toxicology. The second one is this order called opiate confirmation screen. So this is a more kind of intensive screen that gets sent out to a lab through more precise lab techniques such as mass spectrometry. The UTox will come back within a few hours usually of when you order and collect the sample, whereas this one has to be sent out to an outside lab. This can sometimes catch things that the other screen did not, or confirm the presence or absence of substances. So we like to have this as a backup, just to be sure if there's anything that's making us raise our eyebrows on the first screen, we can at least have some data to show if this was, a fluke of a lab sample or something that's likely accurate.
And this is our, we have an opioid pain contract that everybody signs, even if we're prescribing just, one Vicodin tablet per day, right? So it's just, again, creating the culture of safety for both the patient and our team. So it looks like people have already done this is our question, the poll question. The following strategies would be recommended for a patient that scores high on the opioid risk assessment tool. And so the choices are considering weekly scripts for opioid refills, work in collaboration with PCP, who has been writing for opioids in the past, doing routine urine drug screens, establishing a rapport, and emphasizing creating a safer environment for both the patient and the provider.
All right. And Cindy, how are they doing?
Well, actually, the answer was B.
Oh my gosh.
Yeah. So maybe, so all of these like A, C, and D are accept. So, these are other ones that, weekly scripts work, random drug screens work, establishing rapport, but having a collaborative, working, we don't really want another provider outside of the palliative care team. So sorry that kind of looks like some people are still answering, but well, let's go on to the next slide here. So strategies to reduce risk of opioid misuse are prescribing opioids only if benefits outweigh the risk. Every time that I write for an opioid or a benzo, I'm always checking the database, the urine drug screens, prescribing small amounts of opioids at shorter intervals, like the weekly prescriptions, avoiding agents with higher abuse potential, and requiring the use of only one team, like the palliative care team, or one provider to write for opioids. Our team makes sure that there's not another pain clinic involved. It's either us or the pain clinic. Have the pain contract, and to ask the question, why, be curious of why people are taking the opioids. Is it hopefully for analgesic, but sometimes people take opioids for other reasons. So, points to consider, and Vanita has actually shared this, we can make adjustments with the a different opioid, consider adjuvants. And Vanita definitely highlighted the bowel regimen. It's very important. And, the key really is making sure that we're listening. So for mind-body interventions, the question is, mind-body interventions include all of the following except cranial sacral therapy, roofing, kratom, and therapeutic touch. All right, this is perfect. This is exactly the answer, right? Kratom, we do not want people taking kratom. So kratom is an herb that can have adverse effects of like respiratory depression, seizures, weight loss, insomnia. So good job, everybody. Perfect. And these are just a list of some of the mind-body interventions. We do know that the yoga, mindfulness and meditation, hypnosis can be effective. The undercurrent for all of these is really the ability to relax. And it's through that relaxation that the body's innate healing response can happen. And I do want to clarify that, the body's healing response doesn't necessarily mean that it's curing or that the pain is going to be totally 100% gone. But I think what can potentially happen with regards to pain is that a different relationship can be cultivated or explored in relationship to the pain. there is this field of study, and it's called psychoneuroimmunology. And really what this field of study is trying to do is take the spirit, the mind, the central nervous system, and the immune system, and to see how exactly the effects of studying these connections affect healing. And I think the key point about this is the relationship of the body systems and the interconnections. So what we're learning is that our beliefs are the way that we treat ourselves, the way that we treat others, the way that we treat the earth. It really does affect like the experiences that we'll have and like our relationship to symptoms and pain that we may have. And in closing, I do offer the breath work. That's one that I may not use the word breath work, but I do say, have you experimented with deep breathing? Because we know that the deep breathing can help the nervous system calm down. And in that calming down, my hope is that there could be like a soothing sensation in the body that people can connect with, and in that, some relaxation. And in closing, I really wanted to highlight our resource page, but out of all the resources here, the best one that I like is the Palliative Care Network of Wisconsin, the Fast Facts. It's a great resource. You just type in whatever the symptom may be, like, that could be pain or cancer-related fatigue, or, should I have a tube feed or not a tube feed? So it's a great resource. Thank you.
Great. Thank you both so much. This has been, we've learned a lot. I wanted to mention that our questions, that's now open. So we'll be looking for questions and posting those as those come in. While you're thinking about or composing your questions, let me ask about each of your roles with a multidisciplinary team. What are some of the both the challenges and opportunities that you would see when working with others in a multidisciplinary team from your area of expertise? Dr. Rao, do you want to take that first?
Sure, happy to. I think that's one of my favorite things about being part of this team, and a large part of why I wanted to join the palliative care team here at UNC is I think, this field inherently, with the way that we want to make sure all, needs are met for a patient, it needs an interdisciplinary team. It needs providers and, staff who are looking at the problem from all different angles. So to me, it's a joy to work with this team because each member on our team brings a different angle. I'm the lone pharmacist on the team, so I bring, the medication expertise, but I recognize that's only one piece of the puzzle. So what my work often looks like is, even if I'm not familiar with the ins and outs of a particular patient, or I haven't seen them independently for appointments, I'm, getting questions from Cindy or other members of our team of, how to kind of best work through and choose the right medications, how to balance medication needs versus other psychosocial needs, or non-pharmacologic ways of treating pain. I bring that piece, but Cindy, with her mindfulness practice and her very robust set of non-pharmacological techniques, is something that I learned so much from, and that I am thrilled when I can bring her expertise into a patient encounter and have patients follow with her as just an example. So I think we need each other in this work, and it's much more satisfying to do, to feel like my patients are being cared for from all angles by the experts in each field.
That is great. Thank you so much. Cindy, what about from your perspective?
Yeah, I 100% echo Vanita's comments. It's really, it takes a village type of response, and I think everybody contributes in their own way to help alleviate the distress that patients feel and their families.
Great. Thank you both so much. We do have our first question from the audience. Could you tell us a little bit about your feelings about benzodiazepine use with opioids?
I'm going to chime in. I really try to not have people take a benzo with an opioid unless they're in hospice. I mean, of course, there are times that that the benzo is needed. And if I do have to do it, I do a lot of teaching saying, there's an increased risk for sedation with combining both of these drugs together. So that's usually my path when I have this, when I'm presented with this. Benita, thoughts?
Not much to add to that. I agree. I mean, the risk of these two medications together is heightened risk of respiratory depression. So I think we're pretty upfront with patients about that. I think if anxiety is a big component, we'd love to work with them in other ways, whether that's, non-pharmacological measures, getting them connected to other resources, counseling support. We love when people can be seen by our CCSP providers. But also, from a medication standpoint, we'd love to, lean more towards antidepressants that have good anti-anxiety components that are much safer to use with opioids. So things like sertraline or duloxetine that can have that benefit. And the way I talk about it with patients too is, this is a more sustainable solution and a safer option for you.
Great. Thank you. And what I'll do, I'm going to go ahead and mention a couple of other things, and then I'll check back to see if we have any final questions that have come in. While we're waiting for those, I want to say thank yous. I want to say thank you to the people of North Carolina for through their taxes funding the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. I want to thank all of the members of our team who make this possible: Veneranda Obore, John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, and Patrick Muscarella for all of their hard work on this and other lectures. Questions come in, bear with me for just a moment. Looks like yes, we did. So let me share that one last one before we close. Here we go. How do you prioritize which type of mind-body treatment to pursue, i.e. evidence-based, PT preference, accessibility, etc.? Great question.
I would have to say I try to listen and patient preference, because normally if somebody's asking me about that, they have experimented on their own and they have some insight to perhaps what will work for them. And it's nice. I mean, here at UNC, there's acupuncture that I can send people to. So it's more of trying to listen and take it from there. For me, that's how I tackle that question.
Great. Well, thank you so much. Thank you both. As we've learned a lot. This has been extremely informative. Thank you for your expertise and your time today. Thanks to our audience for joining us, and we'll look forward to seeing everyone soon. Take care, everyone, and have a great afternoon.